let's talk about some chest tube drainage output. Typically, when chest tubes are placed, even if it's for a pneumothorax that's just trying to help re-expand the lung, you are still going to see some sort of fluid output. But this is going to vary depending on the reason why the chest tube was inserted in the first place, as well as, your patient's situation, conditions. Are they on blood thinners? Are they at risk for bleeding? In the ICU, we do hourly I's and O's, and so we are really keeping an eye on that chest tube drainage. I want to preface this with every provider has their own preferences as to what they're comfortable with for an hourly output and when they want to be notified. I've seen some that want to be notified if it's more than like 100 to 150 milliliters per hour. I've seen some that are comfortable with 200 milliliters per hour. This here is kind of talking about when a chest tube is actually safe to be removed, like what the maximum total 24-hour amount would be. But we also need to take in account what was the chest tube inserted for? What does the output look like? What has it been like? If my patient had been putting out 20 milliliters an hour of chest tube output and suddenly there's like over 100 milliliters in there, I'm going to be kind of like, what happened? What changed? Is the patient coughing? Is the patient moving? If your patient hasn't moved in a while and suddenly they get up and they dump like 300 milliliters out of their chest tube, it's probably because that's actually been in there. It just hasn't been draining out of the patient because they've been still. Also, look at the output description. Has your patient been draining more of a serous fluid and suddenly you got frank blood in there, or have they been draining frank blood all along? If you don't know what your provider is comfortable with as far as the max hourly output and when you should call them, get a conditional order, talk to them about when they want to be notified for the chest tube output, because truly they're kind of all different and I've just seen such a variation. But always remember, look at your patient, look at the whole situation of what's going on. What does the output look like? Has it been consistent? Has it changed? Has there been anything preceding this large output that could cause that much of a dump? Also, how is your patient? Are they breathing okay? Oxygenating okay? Do they seem like they have something else going on? So yeah, that's my 2 cents. Let me know if you have any questions.